Good afternoon. Thank you very much. Shall I present myself a little bit?
Yes.
I'm a physician.
We have time.
I'm both a neurologist and a geriatrician, and I'm a professor of medicine at the University of Lyon in France. I'm responsible for the Clinical and Research Memory Center of Lyon. I'm member of the office of the French Federation of the Memory and the Memory Centers of France that participated to the building of the French Alzheimer plan, the recent French Alzheimer plan. So it's my pleasure this afternoon to present the ALCOVE proposition for the support systems dedicated to behavioral and psychological symptoms of dementia. You know that BPSD are responsible for an increase of the caregiver burden, a dramatic decrease of the quality of life of both the patient and the carer, and are responsible also for most of the institution admission. But literature is confusing on BPSD support system because it mixes some patient and carer intervention. It makes some evaluation of structure and care organization, and some skills, the evaluation of some skills also dedicated to professional carer. So it appeared to us to try to disentangle the best strategy to help to prevent and care BPSDs in our patient in a three-dimension holistic approach. So the first dimension is represented by structure and care organization for BPSD. They are very numerous and different, but the main thing is to think about collaborative care, multidisciplinary approaches, multi-component approaches. So we have to think about teams that propose some multidisciplinary approaches. They can occur in outpatient consultation services, home care, sometimes day hospitalization units. They can propose also mobile teams dedicated to minor or major BPSDs, sometimes led by a nurse, that's for minor BPSD, or sometimes led by a physician, more for major BPSD. We will see that. Respite care is also very important to try to discharge the carer from the patient for a while, to prevent the decrease of the impairment of the psychological and physical health of the carer. Telemedicine is also very useful sometimes for patients and carer very far from the reference centers. And for patients with major BPSDs, we have to consider specific units in hospitals or in nursing homes, units in hospital with neuropsychogeriatrics competencies. This first dimension, structure and care organization, must be considered all along the patient pathway, from the first stages when the patient presents no BPSD or very minor BPSD, that's the prevention stage. At the moment of the crisis, the major BPSD, at the moment of the crisis here, and after the crisis, when we have to consider some secondary prevention, if the patient turns back to home or nursing home, or when we have to admit the patient in special units. At the prevention stage, when the patient presents very minor BPSD or no BPSD, we have to promote the collaborative care in the ambulatory setting. Collaborative care involving health and social professional, case management, and we have seen this morning that case management is very important for BPSD, as referred to the recent Cochrane analysis. Mobile care, and here some mobile teams led by nurses, telemedicine. The collaboration between the GP and the specialist is very important in the follow-up of this patient before the major BPSDs, and respite care is also important. When major BPSD occur, before considering the admission of the patient in neuropsychogeriatric units that have shown to be very benefits for this patient in literature. Some teams try to show the efficiency of mobile teams dedicated specifically to BPSD, led by a physician at this time, or the efficiency of semi-urgent consultation dedicated also to BPSD. After the crisis, in good condition, we can imagine that the patient can go back to the secondary prevention stage, or has to be admitted in special units in hospital or in nursing home. ALCOVE program allowed to collect a quantitative questionnaire, and that was done. That has been done by the Italian teams. A quantitative questionnaire on the existence of specific structure and care organization in European countries. You can see on the half disk on the right the countries that developed a national Alzheimer plan, and on the left, the countries that didn't have any national plan. And there is a modification of the colors, but that we will manage. So on the half disk on the right, the countries with a national plan, and on the left, the countries without any national plan. You can see the colors have changed, but you should see that on the most of the countries with a national plan have developed mobile teams, integrated cares and case management, and respite units. This is significantly different from the countries without any national plan. So these structures are considered as very important for the countries with a national plan dedicated to Alzheimer's disease. Day hospitalization unit were not considered as very relevant for a patient with BPSDs. I'm sorry for the color code, because yes, that is better. You can see, so on the right, the countries with a national plan dedicated to Alzheimer, and on the left, countries without any national plan. Plain color signifies that the structure seated above is developed all over the country, and strip color, the structure is not developed. You can see that all the countries with a national Alzheimer plan have developed dedicated units in hospital or in nursing home, units dedicated to BPSDs. Mostly in hospital, in psychiatric and geriatric departments. Not so much, it is not different in neurology departments. So all the countries with a national Alzheimer plan have developed this kind of unit. The ALCOVE program allowed also to collect some qualitative questionnaires, qualitative surveys, to try to better describe some innovative programs dedicated to BPSD, from very large national research program to very local innovative action. Here is an example, a French example. This comes from the demonstration in the literature that collaborative care, multidisciplinary care involved in the primary care is efficient to prevent and care patients with BPSD. So the French Alzheimer plan has allowed to spread all over France, home nursing services dedicated to patients with Alzheimer or related disease. These teams are led by nurses. They involve gerontology assistant, occupational therapists, sometimes psychomotor therapists, and under a medical prescription, they may assess housing adjustments, They may provide some patient education, carer education, rehabilitation, cognitive stimulation, and they may help to deal with very mild behavioral disorders and to prevent major BPSDs. This kind of structure is a very good tool to enhance the coordination between all the professionals involved in the ambulatory care of this patient. The GPs, of course, the specialists, the memory centers, the psychologists, and also the speech therapists who are involved at home for this patient. So we are still in the first dimension of this whole strategy, and these are the recommendations for the structure and care organization dedicated to BPSD. So you recognize the pyramid and the cornerstones, and for the ALCOVE group, we considered that the basis of this recommendation must be built on the ambulatory setting and the hospital and nursing home setting. Ambulatory for prevention, primary and secondary prevention of BPSD, mobile STEAM, semi-urgent consultation, respite care, for instance, and the very specific dedicated units, either in hospital or nursing homes, must be considered for patients with major BPSDs. The multidisciplinary approach must be promoted in all the structure and care organizations. Telemedicine may be useful, and also a shared medical and social patient file should be used. It's a good tool to promote the multidisciplinary care for this patient. It has to be kept up to date all along the patient file, the patient pathway, sorry. And finally, some quality and impact indicators can be considered and collected in all the structure and care organization to try to better evaluate these structures, especially the new programs. That is essential for us. The second dimension, the second axe of these strategies is represented by the individualized patient and family carer intervention. The cornerstones for this recommendation, the basis stones, focus on the psychosocial intervention, and maybe you have heard this morning that the psychosocial intervention tailored to the couple, the patient, and the carer are essential to care this patient to better prevent the BPSD or to care the BPSD, to cure the BPSDs. The non-pharmacological therapies are essential. Musicotherapy, bright light therapy, for instance, they are increasing in our care. They must be evaluated, and it's difficult. And we mustn't forget pharmacological therapies. We have to optimize the drug prescription, and we have to try to decrease the prescription of antipsychotics and consider the best drugs for this patient. All this intervention must be considered on a national level, must be organized on a national level, and must be considered under guidelines, national guidelines, and maybe international guidelines that should be thought and written. So that was the second dimension. Why a second dimension? This is orthogonal to the structure and care organization, because we have to think about this second dimension in all the structure and care organization, at the prevention stage, at the crisis stage, and after the crisis. So the first dimension is represented by structure and care organization, all the ambulatory, hospital and nursing home units. The second dimension is represented by individualized patient and family care intervention that should be considered in all the structure and care organization dedicated to BPSD. And the third dimension is represented by workforces and skills, dedicated mainly to professional carer, but also to family carer sometimes, that should promote some education, training of the professionals, clinical guidelines, improvement of programs dedicated to BPSD and to dementia in general. And all the professionals involved in all this structure and care organization, promoting some intervention, must be well educated and well trained to these complicated techniques. So too often, for the moment, our patients are at home, they present some minor BPSD, and we consider that they are minor, so we do not really manage them. They stay at home, it's okay, and we wait for major BPSD that drive the patient to the emergency room where antipsychotics are injected. This is the beginning of a very vicious cascade, and the patient is driven to the hospital units that are not really or obviously adapted to this kind of patient, and then to nursing home. And then this patient, if it's an emergency, are usually in very bad conditions. So that's not relevant at all. And we have to consider these three dimensions at all the stages of the disease, before the major BPSD, before the crisis, to try to improve the quality of life of both the patient and the carer, try to delay the major BPSD, to delay the crisis, and try to anticipate the admission in nursing home or the admission in hospital sometimes. And a good anticipation is very important for all that process and for the quality of life of the couple, the patient, and the carer. So these are the whole recommendations for the BPSD support system, the 3D, the three-dimension recommendation, as I would say. So the three cornerstones, the three basis stones of the pyramid are represented by the structure and care organization that should be dedicated to patients with BPSD, specifically, individualized, tailored patient and caregiver intervention, and the development of workforces and skills for mainly for the professional involved in all these structures. This should be considered and thought all along the patient pathway. It should be part of a public campaign promoting BPSD prevention and management, antipsychotic risk, and this should be also considered, as we can do, as a multidisciplinary approach, multi-component approach in all these structures and for all these interventions. That's the whole recommendation for of the group. So I would like to thank my colleagues from the Haute Autorité de Santé, HAS, mainly Armelle Lepère-Desplanques and her team at the HAS. My colleagues from Finland, led by Harriet Finesovori. My colleague from France, from the physicians, Caroline Robot, who worked on the psychosocial intervention issue. And the Italian team also worked on the quantitative questionnaire, the quantitative survey. And I thank you.
Thank you, Pierre, for that very interesting presentation.